episode of Ultrasound Podcast. In this episode, we have the pleasure of welcoming Dr. Thomas Lokkegaard. Dr. Lokkegaard is joining us all the way from Copenhagen in Denmark. Dr. Lokkegaard practices as a general practitioner in Denmark. He also is an avid practitioner of Point of Care Ultrasound in general practice. He is the co-founder of Danish Society of Ultrasound in General Practice in 2017. Over the last 17 years, Dr. Lokkegaard is practicing general medicine. He is also the research assistant at the Center for General Practice at the University of Aalborg, where he's working along with Associate Professor Camilla Andersen and Professor Martin Jensen. It's a great privilege having Dr. Lokkegaard with us. Please welcome Dr. Thomas Lokkegaard. So, Thomas, thanks for joining us. I believe you are working in Denmark, which is quite in the opposite hemisphere from Australia. It's a great pleasure having you here with us. So, first of all, tell us a little bit more about your general practice background, Thomas.
Yeah. Hello, and thanks for having me for your POCUS program. Yes, I'm a GP in the greater Copenhagen area here in Denmark, and I've been a GP since 2007, and I've performed POCUS in my clinic since 2016. My point was my interest in point of care ultrasound really began with me training in cardiology and internal medicine for a couple of years before I began my education as a GP, and I learned how to perform echocardiography, and I thought when I changed my specialty, I thought I would like to introduce ultrasound in general practice. And it took me some years before I could get started with that because it needed the financial, my finances to be better before I could buy a scanner. So yeah, so we really started from 2016. And in 2017, I, together with some colleagues, we established our Society of Ultrasound for General Practice, and from there on we have worked very intensely for documenting and finding out how we should use point of care ultrasound in Denmark or in general practice generally. And yes, yeah, so that's my background really. And right now I'm affiliated with the Point of Care Ultrasound unit at Aalborg University, where I'm working together with Associate Professor Camilla Andersen and Professor Martin Bach Jensen. And really we have tried to find out how POCUS is going to be used, and really finding evidence-based background for introducing this in general practice. Yeah. Mm-hmm.
Excellent. Thank you, Thomas. I see that you have got a very wonderful POCUS journey. You have started even before becoming a GP, you got some interest, you used it, and now you are just continuing it and evolving it in your current practice, which is fantastic. And also I noticed that you have got multiple publications and you're affiliated with one of the universities in Denmark, which is fantastic. So we'll touch base with some of your publications, and I'm pretty sure my audience will love to hear from you about some of your papers as well. Thank you for that. Now, in your POCUS journey, can you share with us a few interesting cases that you might have, and that I'm pretty sure my audience will love to know about your personal experience?
Yes. It was actually, when you posed me that question, it's actually difficult to find because I have so many cases that I want to present. But one of the main goals the cases that I brought is to really show some very simple scans that you can easily answer with a yes or no. That's it's very important for me to be precise about what we use POCUS for, because it's no secret that it's controversial with some of our colleagues. So yeah, I would like to share two cases with you, and I don't know, yeah. And this is the first one, and actually one of the modalities that I use very much. That's scanning for the presence of pleural effusion. It's a very easy scan to perform, and it's very informative. And I use it, in this case, it was a 60-year-old woman that I know very well in my practice. She's kind of the worried person. She comes very often with different medical problems. And now she came to me with a 4-week history of shortness of breath. And she actually gained some weight, which I didn't think was something very peculiar or very unusual for her, because she had like these weight gains and losses all the time. But and I listened to her. I did my usually examination with stethoscope. Didn't really find anything on the ordinary examination. She didn't have any signs of incompensation. And I said to myself, well, maybe this time I should perform this ultrasound examination. And I found this pleural effusion on her, both sides. Actually, this is, I think, the left side, but there's also a pleural effusion on the right side. And so this really was a very informative ultrasound case, because it allowed me to be more precise in my further workup of this patient, because we really needed to know if this effusion was a malignant or not.
Mhm.
So she was referred to the lung specialists in our mother hospital, you can say.
Mhm.
Yeah, yeah. So
And
it was
what
not
was
asthma; it was
Mhm.
pleural effusion. Yes. Mm?
It is an excellent case, and we see this type of cases all the time in both emergency medicine and urgent care and GP practices. So I find it really very useful when we use the ultrasound and when we show the images to the patients that this is your problem. They know exactly what is happening in front of their eyes, and they take the information so well. This is really fascinating example. And I believe that you have got another interesting case.
Yeah, this is actually this is a woman that I saw in the summer here. She was a 40-year-old woman. She came with me to me with a 4-week history of pain and swelling of the right foot, the forefoot actually, just in the middle of the foot, and she had no trauma or anything. She had went to the emergency department and talked to the acute care doctors there, and they told her that she probably had a strain or had done too much exercise, so they just prescribed some anti-inflammatory medication and compression. And she came to me; she couldn't understand why she still had these pains, and I was just a little bit. I didn't really know what it was, but I have a good experience with doing ultrasound for fracture diagnostics. And so I performed an ultrasound on her forefoot, and she had this stress fracture of the third metatarsal bone. And that was, I referred her to the A&E department, and the X-ray showed the same. So it was a very good example of when pain is coming without any any thing that could explain it. It was very useful for me to use that. Actually, I had the same patient a week later, but on another woman with the same problem, and she
Mhm.
had a stress fracture as well. So So that was a very interesting case, actually. Mm.
Excellent case. That we see this all the time in the emergency medicine. I don't know about Denmark, but sometimes in many of the emergency departments or even the GPs, we don't have the access to the radiology 24/7. And so during this out of hours time, sometimes we use the ultrasound to diagnose it, and to further assess the patient, we might do an X-ray. This is again another interesting case. Thanks for sharing those.
Yeah.
So I see that you have got a lot of this use of ultrasound over the last several years. How did you find the impact of the point of care ultrasound in the patient care, and how this has changed for your assessment and treatment of the patients?
Mm-hmm. Yes, really. I mean, for me as personally, it's been very, very useful for me, and now I've integrated it fully in my work of my patients, and I use it quite commonly. I use it 2 to 4 times each day. It has a very it's very easy, and I can do it pretty fast. It allows me to diagnose the patient, to find out precisely, or give me an idea of how this patient is going to be worked up down the line, and really for patients to be directed in the correct direction if they're going to be referred to other secondary care or other specialists. That helped me a lot. And the other thing that I would like to stress is also that for the patient, it allows me to show the patient what they are suffering from. So it really gives the patient some more clear idea what they have, what the disease is. And actually, just that information can make the patient more calm, and it allows me to maybe end the consultation there without referring this patient further. So it also has a kind of learning potential for the patient. And of course, when I do the diagnosis, it allows me to direct the treatment more precisely. So if I have a patient with pain in a joint, it allows me to see, okay, this is a joint infusion, and maybe I can do a procedure on that. So it of course allows me to direct the treatment more precisely.
Excellent. So from your experience in the general practice specifically, for example, so you have mentioned about pleural effusion case, you have mentioned about fracture. I'm pretty sure you use for pregnancy as well. Is there anything else that you use for this POCUS for?
Yes, for me, I am together with 2 women in my practice. So we are 2 women and me. And my female companions use it for obstetrics and gynecology, and they find it very useful for IUD placement and, bleeding in the first trimester of a pregnancy, because that allows us to end the workup there. Because, if you have a small bleeding and you don't have any other signs, and you have an intrauterine pregnancy, then it's very safe to have this patient, to calm the patient and say they should come back if there's any other problems. What I use it, lung ultrasound is a new thing. I think is very useful. I have a lot of patients which have a low CRP or not very clear in signs of infection yet, because they come very early in GP practice. And when I do my lung ultrasound, I can visualize pneumonia, even if they don't have clear-cut symptoms of that yet. And then, of course, in rheumatology, I mean, that's a big area. I think maybe 70 to 80% of my consultations are centered around diseases of the joints or muscles and tendons and so on. So shoulder patients, Yeah, I can go on and on. There's a lot of things, but that's some of the very useful things I've done.
Excellent.
Yeah.
Yeah, it's very nice to see that the ultrasound can be used in so many different patients. But
Yes.
that brings about our next topic. That what are the challenges you find in the use of ultrasound in your general practice, and
Mm.
how are you going to address those challenges?
Yes, that's a very good question because that, as I mentioned before, it's no secret that this is a controversial thing. A lot of our colleagues actually just in our own profession and also in other specialties, I guess probably you've experienced that as well, are raising questions about safety and are we good enough to do this? And that is one of the challenges that we of course meet with it, like the surroundings or the external factors about this POCUS problem. But internally, you can say what really is a problem that we need to address is, of course, false positive answers, accidental findings. That's really a problem that gives rise to a lot of questions because are we finding too many things
Mm,
that don't have any relevance for the patient? And does these things lead to unnecessary downstream further workups?
mm,
A lot more x-rays, a lot more ultrasounds, because we are not sure what we see. So this is one of the main things that we are working on to find out in my own practice, I've experienced more times when I find things that I'm uncertain or unsure about.
mm,
And so that's something everybody has to address. But I guess it's not specific for our specialty. I guess
mm.
it's probably going to be like that for many specialties.
Yeah, even in the emergency medicine, for example, we have got the similar issues. But
Mm,
in Australia specifically, we are developing more robust training programs,
yes.
and we are getting better, which is a
Hmm.
good sign. And that also brings about your the training and accreditation, but we'll talk about that in a minute.
Hmm.
Um, so in one of your papers, you have mentioned about the use of point of care ultrasound, which is
Mm,
performed by general practitioners. Does it lead to inappropriate care?
yes.
Can you tell us a little bit more about this
Yes.
interesting
Hmm.
topic?
Yes, I can tell you a little about it. The background for this study was that we performed a couple of years ago, we performed a study with 20 general practitioners.
Mhm.
These practitioners were pretty experienced and they were assigned to do ultrasound where they performed ultrasound and they needed to tell to point out the diagnosis in the beginning, and then after they did the scan, they should say if whether or not they changed the diagnosis
Mhm.
and what the consequences of this scanning was. And then we did 6 months follow-up of these patients to find out whether or not how did the ultrasound influence the further workup of this patient.
Mm.
And I think we had about 500 patients and followed them from 6 months to see if there were any adverse effects of this. And I mean, to be a little bit superficial, but in general, there wasn't any serious adverse effects of these practitioners doing ultrasound.
Mm.
There were some specific areas where we need to look further and be more cautious. And one of the areas that we found problems was when the GPs began scanning for ovaries, for instance, or when they tried to find out whether or not there was a suspicion about malignancy. Then we should be very careful because that led to some cases of unnecessary worrying procedures and more diagnostics workup, which was not necessary if we found out later. This is really one of the areas where we really try to find out, because a lot of criticism are actually about this area, about safety and how does care develop after we do ultrasound. Yeah. So that's a publication that we're happy about. We did. We now need to see of a more general population of 250 practitioners. We have just completed a randomized study, including 250 GPs, because we needed to see what the result will be when we apply it to a more general population of GPs. This study was with 20 pretty well trained doctors. So yeah.
Excellent. So that particular study of yours, that has a significant impact on the general practitioners as a whole, and that has helped you to formulate some training and also, I believe, some auditing to see if there are any wrong diagnosis or false positive, false negative diagnosis, which is very good. Thank you very much for having that.
Yeah.
So that brings about the interesting topic of training of the GPs, for example, or the clinicians on the training of point of care ultrasound. So over the years, what is your experience? How did you find that training is evolving, and what is the training situation in your practice?
Yeah. When we started this, we really didn't have any really good courses for GPs. Usually the courses were held for specialties in the hospital setting. So when we started this, we thought, well, maybe we can just apply the courses that they use in the hospitals to our sector as well. We found out that this was not a feasible solution, because we don't have the same patients in our practices as they have in the hospital. So we really started by the first question we posed to ourselves was, what is the curriculum for a GP going to be? Because we found that the curriculum for other doctors was not satisfactory for the doctors that we wanted to train. So that led us to do some studies about what is relevant for GPs. And the next thing we wanted to ask ourselves was, how should we train the GPs? Because there are some factors in general practice which are innate to general practice, and that is time. We have a very limited time schedule. We don't have access to supervision as well. We have we don't have the same possibilities to train ourselves. There's not many courses, so that we needed to address. So we've come up with a solution where we really focused on doing courses that are longitudinal. That we have a 3-month course, which is separated by where we have 3 days separated by some months, where people can train for themselves, and they have a close supervision of an experienced doctor, which can supervise them in the learning period. And then afterwards, we do some assessments of the GPs to find out whether or not they acquired the competencies. So that is really where we've come to now, and I think that's going to be a good solution going forward.
That's excellent. Yes. So just wondering, with your training in this ultrasound, you said it goes over several months. Is it done by the university, or it is just like the training provider? And do you involve the sonographers or radiologists for this training, or it is GP training only?
Yes, it's not the university. We have our Society of General Practice has a big educational portfolio. That is that they teach us uh, uh, as a society. We have courses in that setting. So the university setting is not relevant for us. So when you are GP, you can go to courses which are arranged by our society, and they provide the ultrasound courses.
Mhm.
When you are a training or a resident at the hospital, you of course receive the training there. We have a lot of doctors which are or who are trained at the hospitals as well. So there's really two things. And then as a student, medical student, so of course you have the university providing training for the students. But when you are trained GP, we have the courses are made in cooperation with our society, our scientific society. And we have trained a group of GPs to be trainers. And we have, so we don't use specialists for training. We use GPs. And that's a very, that's a thing we have thought was very important, because GPs know what is important in GP practice. We had before we had cardiologists, we had gastroenterologists, and we found out that they go too much in detail. People zone out because they probably talking about the segments of the liver, and so it gets too detailed. So we use GPs which are, of course, trained very thorough in POCUS and very experienced. So that's how we go about that.
And excuse me. And do you use any logbook or any accreditation process?
We in the courses that we have made now, we use Teams as a platform where we have a log where people upload their scans. It's the Danish way of doing things are a little different than other places, because we don't have the accreditation system yet. For instance, you have our system is based more on trust and in acknowledging that the doctor, if they feel qualified for it, they can perform the ultrasound. So we don't really have this kind of accreditation or examination of our doctors, and that goes not only for POCUS but for all other aspects of GP care. So that's to address that problem. We have tried to find ways to do audits. So the GP in connection or in cooperation with other GPs can do audits where they find out how their performance is. And that's something we're going to publish very soon, a study about how do you perform an audit of your POCUS practice.
Thank you for sharing that. So that's very
Yeah.
important
Mm.
from what is happening in Danish GP practice, which is fantastic. Thank you. So you said that you do some audit and quality assurance process to make a check and balance. Do you think that affects the medical legal aspect at all?
Sorry, say that again.
From the medical legal aspect, for example, if
Yeah.
patients are not happy and if they go to the court, for example, I don't know about what happens there in Denmark, but that happens in US.
They do as well.
In Australia as well.
That's a very good question. We haven't had any instances of that yet. I've seen a publication from the US where they have done where they examined if they have any litigation with use of POCUS in, I think it was in acute care medicine, And I think the study showed that they had very few instances of litigation or medical legal problems with their use of POCUS. So we really need to see. It's new for us. It's really a development that has been going on for 5 years. So it's going to be interesting, or it's going to be. We haven't had any problems with that yet, but since I mean, in Denmark, it goes for many of the different things that we do in general practice, that we don't need as accreditation, so it would probably be based on best practice, and if there's proper documentation of the scan, I would think that would be the result. But we don't have any experience with this yet.
Thank you. So when it comes to training, you have got a few publications. You have published this large paper, systematic review on the education of practitioners on the use of POCUS. And that was a great paper. Do you like to update us about the salient features? What?
Yes. So this publication was, first of all, when you do systematic reviews, we did another one previously about more general about how POCUS is used in GP practice. You found out that there's very few high quality publications concerning training in general practice, and that's because it's a new area. I guess, and so it's very difficult, we found out, to find high quality papers describing the use of how to educate general practitioners. But the main findings of the study was that you really have to have the best results comes with training where you have longitudinal training. The training where you just pop in for 1 day and then you learn a little about POCUS, and then you think you can go home and train and perform POCUS is probably flawed. You need really longitudinal training, and that means 3 to 6 month training where you are followed by somebody who can teach you as you go along and as you gain experience. That was one of the main findings of this. And then, of course, and that's not very surprising, courses where you have hands-on training are better. So when you and it's hands-on training both with what we call, just healthy individuals who's going to be scanned, but also
Volunteers, you mean?
Volunteers,
yeah.
who does not have any diseases, and then combine that with patients with diseases. So we have done a combination of both when we do all courses. So that was actually what we could extract from what we could find of studies. But as I said before, this area is very poorly examined, but I think with the POCUS publications, which have gradually been more prevalent now, I think will come a lot more about this problem. But of course, there's some really fundamental things that's very different in general practice than from hospitals, and that is you can't just ask somebody who's better than you in GP practice. You are alone. And that's really a fundamental difference. So it raises some questions that are specific to GP practice, and we need to address that, and we need to do more research to find out how to go about this problem.
Yeah, that's a very good finding, and the good thing is it is evolving, and more GPs and more doctors are taking this up. And as we use it more, I'm pretty sure there will be more publications, and that will give a more robust systematic review findings.
Yes. Yeah.
So we have talked about the integration of the POCUS in general practice. How do you find your application of POCUS. We briefly talked about it, and that will also bring about the next topic, which is the patient perspective. So how do the patients take from the use of it? You have mentioned a couple of cases, and you mentioned that the
Yes.
patients were very positive about it. And from my personal experience, I know that the patients love it. If I show them, this is your heart, this is your baby, they just love it. What is your
They love
experience from your use of POCUS?
And Camilla performed. Camilla was associate professor, who are both the primary. She has really a lot of knowledge about this area, but she did a publication some years ago about the patient perspective, and it was actually in a study she did in connection to the other study I mentioned about with the 20 GPs. And after the 20 GPs had performed the ultrasound, they were given a questionnaire where they were asked, how do you feel about this? And how does it affect the consultations? And I mean, there's no problems associated with this. People love this. The patient thought it improved the doctor-patient relationship. They thought they were more thoroughly examined. They thought they were taken more seriously. They had a better understanding of the health problem. They made it feel more secure. So there was just so many positive aspects of this. But of course, it doesn't show anything about the outcomes. I mean, maybe the patients think it's very nice, but it doesn't really tell you if the treatment was correct or not. But it doesn't affect the patient-doctor relationship in any negative direction, because you could argue that putting machine in between the patient and the doctor could make some patients feel that the doctor didn't see them as a person or something like that. But that's not the incidence we could find out, and that's very well documented. So that's not a reason for having any concerns. But really, the concern is, of course, that the patient doesn't know any better. So really, the focus should be on what is going to be the consequences for the patients. And that's really the next topic that would be very interesting to study.
Yeah, yes, I think that's a very important point as well. A shared decision making about the patient care, and if the patient gets more information about their body or their disease or their condition, then that shared decision making process makes it more robust and more comprehensive.
Yes.
From my personal experience, the patients love the ultrasound as I love it. And especially when I show them the findings, they can get the information, the communication level of communication that improves significantly when I use the point of care ultrasound in my patients.
Yes, and it applies as just to, I mean, very simple problems, which is, for instance, tendinitis or something that is a big problem for the patient, but in a doctor's sense is very not very serious disease. But when you can visualize the problem for the patient and explain, okay, this tendon is inflamed, you have these signs, then the patient is usually very satisfied, and you don't need to refer them to further examinations. So I would think my thesis is that, or my thoughts about this is to save money by applying this. I can't document it right now yet, but we are working on documenting that. But in my experience, it really avoids a lot of downstream imaging and specialist consultations.
That's fantastic. It's always nice to know about that. So, as you have mentioned earlier, that over the last few years, the POCUS has evolved in different ways. What is your experience, and what do you think the point of care ultrasound is going to change over the last few years in terms of technology, in terms of the way we use it, document it, and how ultimately it's going to affect the patient care.
Yeah. First of all, I think with the knowledge that we're creating and all the and POCUS generally in all specialties, we experience an explosion of knowledge about this, and it will probably just in itself be propagated very much in the future. And what I see as very important for general practice is artificial intelligence will probably be a very big thing, because it will quality ensure the scans, so we know that when you see something, you probably would do better. I don't know if that's documented. I don't think there's any solid documentation for that, but that would be my best guess. And so AI will be very important. For a GP perspective, we can see that the improvement in handheld devices is going to be very important for the implementation, because the handheld devices are cheaper, easier to manage. We generally have actually told our course participants to avoid handheld devices, because we experienced that it's very difficult to learn POCUS on handheld devices, because the image quality is much worse than on high end. But with the new handheld devices, I think that's going to be, I don't think it's going, I don't know what you think about that, but I would think it will get so much better that you can easily perform ultrasound with handheld devices in the future. So that's our experience. What we really are interesting is virtual realities in the education. We have companies in Denmark which are very do very nice virtual reality simulators, and that would be a thing we would like to implement in our courses as well, because I think that would help the learning curve to be more faster than it is now. So that's something, some of the things that I think are exciting about the future.
Yeah, thanks for sharing that. I think I agree with all you have just said about the future. The future is very bright. We have got artificial intelligence, including the machine learning and deep learning. We have got the technologies evolving tremendously. I mean, I've been using ultrasound for almost 20 years.
Yes.
I can remember those 20 years ago, the machines were bigger. It took a lot of time to just boot the machine.
Yeah.
And the quality of images were not that great in comparison to even the handheld device these days.
Yes, I know.
And, and some of the devices nowadays, the latest some of the devices I have seen, they can even you can do the Doppler with the Doppler echo with this handheld device. And they are wireless. You don't have to think about those contamination, cleaning, and this type of things. And the other thing I found with this new technology is that the training, as you have mentioned, you can use the VR, the virtual reality. But at the same time, for example, if I do an ultrasound and if I want to show it to you and get some feedback from you, I can just upload it and you can have a look.
Yes.
And you can give me the feedback. I think that's fantastic with this internet technology and the way we use this ultrasound. That's really fascinating.
Yes, it is, and it's going to be very. But the thing about the future is also that we really lack a lot of high quality studies which can tell us about the consequences of this, because you can be very technology fixated and think it's all very exciting, but we really need to see. And one of the questions that I think is very important, that is, we have, a subgroup of GPs that find this very interesting and are very technology excited about this. But we also have a large group of GPs who's, ordinary users, I would call them. And how do we get this their training up to a point where they can really use that in their work. I don't know how it is in your place, but you know that in we have these first movers and very excited about this development, but we really want to be to have our population to have access to imaging more generally, and how do we ensure that? That's really a big question for us.
Yeah, so that is happening here as well. But the good thing is that if we started from the very beginning, for example, from the medical students and the trainees, then when they become GPs or a specialist, it becomes like a part and parcel of their practice.
Yeah.
And that is what we are trying to do here as well. For example, emergency medicine, some of the modules in ultrasound that is mandatory now, which means that when they become consultants in 4 or 5 years' time, they will have that knowledge as a part of their training. So they don't need any extra training to get that basic level of or functional level of knowledge and skills.
Yeah.
The other thing we are trying to do, which is not done yet, but we are working on it, is to get the medical students to get the foundational level of knowledge and training from the medical school. And that is the only way I feel that on one hand from medical school, the second one is from the society or the college of general practitioners, for example. If that is made a part of the training program, or if it is made mandatory, then the future GPs or future specialists, they will have that point of care ultrasound training, at least at the foundational level.
Yes, I agree very much. We have, we have actually just done a study where we did a national survey of where we asked our, just newly educated doctors how they were going to use, if they're going to ultrasound in their daily work in the future. And 80% of these students thought they were going to use POCUS in their not only GP practice, but just generally. And 60% of the participants thought that they were going to be that POCUS were going to be if POCUS were more implemented in GP practice, they would consider that specialty. So we also have, furthermore, the good things about it is going to be recruitment of doctors to our specialty. So not only will the future doctors have a better foundation, but also think that POCUS is attractive in itself when you choose your specialty. So that is a development that we find very exciting, because, of course, I don't know if it is how it is in Australia, but we have problems recruiting primary care physicians in Denmark.
In case of the general practitioner, we have got quite a bit of interest, and as you have rightly said, that with regards to the ultrasound, when we incorporate the ultrasound, the trainees love it, and so that's the most exciting part of it. That the future is very bright, especially from point of care ultrasound point of view. You have also published this article about the a systematic needs assessment. Do you like to tell us a little bit more about this? It's a recent paper from 2020.
Yes, that's a recent paper. It connects to something that I mentioned at the beginning. We really wanted to, with this paper, to find out what modalities are the most relevant and important for GPs to master. Because if we don't know that, it's very difficult to make courses that are relevant for the practitioners. So we asked 40 pretty experienced GPs in the Nordic countries, which scanning modalities do you find most relevant in your job? And then we performed a Delphi study where we asked these doctors in 3 steps, and in that way we tried to prioritize these modalities. So we got a list of modalities in the end that showed us which scanning modalities were most relevant. And this study formed the basis of our current course, which is a basic course. And these scanning modalities, we have 10 of them in our course that are based on this knowledge which is created from this study and some other studies we performed as well. So what we experienced in the beginning before we made the course here is that a lot of the courses that were available had a curriculum that was defined by acute medicine and by cardiologists, for instance, where you had a too much focus on echocardiography, complicated abdominal examinations, and for instance, no rheumatology, for instance. So that was very important for us to do this study, and it's a study which was performed among our peers, among GPs. So that's the bottom line from this study, and yeah, so some of the scanning modalities were very simple. One of the top 10 was residual urine, for instance, to determine if the patient has residual urine. It was about placement of IUDs, pregnancy, live pregnancy determination, gallstone, and so on. So it was some of the findings from that study. Yeah.
Excellent. Thank you for sharing that. Thomas, you have been using this ultrasound for quite a while, both in practice and also from the academic aspect. What will be your main advice to the clinicians, like the general practitioners or the emergency medicine or urgent care doctors, about the use of POCUS in their clinical practice?
Yeah. I think there's some things that are for the individual GP, they need to find out what would they like to use POCUS for, because you can have a special interest and then it's fine. So find out what are your interests for POCUS. Keep it simple. That is, do scans that are simple in the beginning, and then add your do more complicated things as you go along. What I experienced in my own clinic is that we really wanted to include all our staff and all our other doctors in the implementation of this, because if you want to perform this, there can easily be misunderstandings about who does what scans, and you perform scans it takes you longer time, and then other doctors need to do more of the other stuff. So if you have understanding among your peers or among your colleagues, it's much easier to implement it. And what we also says to our course participants is find a mentor or find somebody who is more experienced, and establish a network of like-minded colleagues in your area. So you can we do some after hours courses or meetings where we can discuss our findings, and we can have specialists coming out and tell us about new developments, or look at our scans and say, well, you should do this, you should do that. So in the beginning, you really need to be focused on spending some time on this, so you get the right training and you use the amount of time which is necessary to be competent. We have a very nice network in my area where we 20 GPs meet 4 times a year, a couple of hours,
Mm.
and we do some. Share our thoughts and experiences. So that's very nice. Yeah. So that would be some of my advice about this. But one of the most important thing is know your limitations. Keep things simple. Buy a good scanner so you have the right equipment. Because the scan quality and the abilities to be a good scanner are also connected to the pictures that you acquire. So don't go to Alibaba or anything to buy a very cheap machine. Buy a good scanner, and you'll be better off. So that was some of the advice I can say to other GPs that wants to get started with this.
Thank you for sharing the advice. I'm pretty sure this advice is applicable for other POCUS practitioners in the emergency department, urgent care, even the paramedics or the nurse practitioners, for example. These are very important advice. Thank you for sharing that.
And just a very simple thing, actually, which we found out would be a very nice way is secretaries. We found out that secretaries in our clinic. They didn't really know what we used ultrasound for. So in the beginning, they were just they just didn't know. And then after we told them what this can be used for, they can give advice to the patients when they call and really do visitation much better.
Yes.
And then they can put the right patients to the right doctors.
Excellent. That's great. Yeah. Thank you. I see that you have got multiple papers and publications. So for our audience, if anyone is interested to know more about those papers from Dr. Thomas Lokkegaard, this is a list of the papers. All right. That brings us to the end. The time flew very fast, Thomas.
Yes, it does.
Thank you very much for sharing your thoughts and expertise and sage advice for the clinicians.
Yeah, thank you.
I'm pretty sure.
Thank you for having me. It's always a pleasure.
No problem. Thank you. Thank you.
Okay.